Hey, my name is Alex Crowley. I am president of the local surgery interest group, and I'm here with Anna. Anna, say
Hi, my name's Anna. I'm the secretary of the group.
hi. And Joe.
I'm Joe. I'm internal medicine president. I'm a scrub. I do what I'm told.
He's our guest star for today.
Yes, he's the celebrity guest. And today we've got your back. So this is the first of what we hope is many helpful PowerPoint and recordings. The idea is that this is going to be a tool for you to look at right before you go into lab, because we know that the first year of medical school can be a lot. So this is something that maybe if anatomy fell on the back burner and you need something to get you up to date right before you go in, you can look at it. And then we've also got the pathology, and we'll talk a little bit about what you can expect to see on a test if there's something difficult. We explain that as well. So let's get started. So your first week, you're going to be doing two dissections. You're going to be doing back, and you'll be doing upper limb. So the next few slides, we're going to describe the muscles of the superficial back, intermediate, and the deep back. So I'll start with the superficial. So first you've got the trapezius muscle, which has three parts: the ascending, the intermediate, and the descending. It's accessory nerve supply, which is one of the cranial nerves. You'll get more into that when you get into neuro. And it's got the superficial branch of the transverse cervical artery providing it blood. The origins and the insertions, you can go back to Gilroy and review that yourself, but that's really not what these are about. So next you've got latissimus dorsi. This is kind of the big muscle that you use to do pull-ups. So it's innervated by the thoracodorsal nerve, and it's got its blood supply from the thoracodorsal artery. Rhomboid minor followed by rhomboid major. So these two muscles are kind of deeper to the trap. They're innervated by the dorsal scapular nerve, and they get blood from the deep branch of the transverse cervical artery. And now we've made it to the intermediate back. Anna, Joe, whether you want to take this?
Sure. All right. Intermediate back, got the serratus posterior superior muscle and the serratus posterior inferior muscle. The innervations for these muscles come off of the intercostal nerves on the vertebrae. So the serratus posterior is T2 through T5, and the serratus posterior inferior is T9 through T12. They're also accompanied by, in the middle back, the splenius capitis and splenius cervicus muscles, and the erector spinae muscles. Those include spinalis muscle, longissimus, iliocostis, and I think that concludes the erector spinae muscles. They're all innervated by the dorsal rami of the thoracic nerves. So that's going to be, T1 through T12, I guess.
So out of all those muscles, which one do you think you're most likely to be asked about? If you get pimped during anatomy lab?
I think you would have to know spinalis, longissimus, and iliocostalis. Dr. Thompson will definitely point to them and ask you which one is which, so know the order.
Yes. And that's why I asked, because I specifically remember in lab, we couldn't even see spinalis. It was so deep.
Yeah.
And it's so close to the to the spinous process that she loves to ask you, oh, what muscle is this? Expecting for you to say spinalis, and it's actually the longissimus. So,
Wrong.
Yeah. So just watch out for that.
These are all possibilities, by the way.
Yeah.
Could be asked, may not be, though.
Okay.
Not a guarantee. So now we'll get into the deep back. So the transversospinalis muscles include the semispinalis capitis and thoracus muscles. We'll have the multifidus muscle and the rotatoris muscle. That's also another part of anatomy that you won't ever know how to pronounce anything. So these are all innervated by the dorsal rami of the spinal nerves. These are probably going to be a little bit difficult to see when you're in an anatomy lab, but you should at least know them because you might be asked.
And you definitely, just one thing, just to don't be scared by these muscles, because like a lot of these, you can just call them the rotators. So there's like the thoracic rotators, the short and the long. So the short one is the short rotator, and the long one's the long rotator. And then next to them, you've got the thoracic elevators. So levator thoracis. Okay, this is definitely, pay attention. We've gotten so many questions about the anatomy of the spine. This is something that I definitely glazed over when I learned it the first time.
Yeah, same.
And then I got like 5 questions about it. Would you agree, Joe?
Yeah, I've gotten a few of these for
Yeah.
sure.
Especially from this angle.
Yes.
I think they'll show you a picture of this on a test or a quiz or even just in lab, and you'll have to know each one of these parts of the bone.
Yep.
Which, I mean, looking at it, it's like, oh, that's not hard to memorize. But then when you get it on a test, you're like, wait, what was that?
And they show it to you in a diagonal angle or something?
Yeah.
Okay, so specifically, I've gotten this question a few times where they'll show you a picture of a vertebrae and it's fractured, and they'll just point to it. And it's usually the pedicle or the lamina that's broken. So the pedicle is the one that's going to be more anterior, because you have to remember that right here, this is the spinous process.
So that's the back of the
So this
spine.
this is the posterior of the spine, exactly. So up here you've got the pedicle, and then back here you've got the lamina. And generally, when there's a fracture, it'll be here or it'll be here. One other thing that you should definitely look to, we've got a list of useful resources at the end of this presentation, but you should definitely know the difference based on looking at it between a cervical, a thoracic, and lumbar vertebrae. So you're going to have a greater vertebral column depending on how many white matter tracts are passing through, right, as they're messengers. So one of the resources I used was Ackland's Atlas. So if you go through the Skelton and Mercer Library, you can go find that resource, and they pay for it. They have a subscription, and he has a whole 15-minute long video just about these vertebrae, and I promise you it's worth your time to give it a quick watch.
Definitely.
The only other thing that I would say is that our next slide, we talk about, if you move on, right? Yeah. So we're going to talk about the different ligaments of the spine. That's a great topic. They love asking questions about that. Joe, do you want to talk about that?
Sure. So you got the anterior longitudinal ligament. It's a bit thicker, I believe, and the posterior longitudinal ligament is thinner, so that one gets torn easier. If you'll skip a few to the posterior long. Right there.
Yeah.
Okay. And then you've got the intervertebral discs. So herniations occur from the nucleus pulposus right there in the middle outward through the annulus fibrosus, and usually they'll go into the vertebral canal, like impingement nerve, and that's when people start to feel issues. Also, kind of high yield is the ligamentum flavum that can get osteoarthritis and kind of osteophy, and that's another pathology thing that you'll learn about later on. The supraspinous ligament, interspinous ligament, and ligamentum flavum are all, three that you could be tested on. I think we've gotten a question or two on those as well. You can move on to the next one. So here's a picture of the disc herniation. You can see it impinging the nerve as it comes through the annulus fibrosus.
Real quick, because they're going to be first-year students, can you explain what the annulus fibrosus and the nucleus pulposus are? This is a good picture for that, I think.
I can't remember exactly. I know the derivative of it it starts with like embryology, and
whoa, we'll keep it simpler than that. Okay, so for all of you who are listening to this, we're sweating right now. What you really need to know is just that the nucleus pulposus is the center of the IV disc. And so it's kind of like jelly-like substance, and the annulus fibrosus is thicker and it's around it. And so what happens is the jelly can start to pour out if you get a hole in the annulus fibrosus. And so like Joe was saying, it'll generally kind of perforate the posterior ligament. It'll go posterior laterally, and then it can impinge a nerve. So you're definitely going to be asked questions about that this time, and that's going to come back up in neuro as well. So know the anatomy of the vertebrae in the column.
That's good. Posterior laterally. Remember that too.
Yeah, that's big.
That's the herniation direction.
So basically what you need to know is that so if you get whiplash, you're going to damage one of the ligaments, right? So if you look at kind of A over here, you've got hyperextension, so going backwards, right? So if you get hit from behind and your head goes backwards, or if you're a quarterback and you get tackled and your head gets pulled the other way, you're going to injure your anterior longitudinal ligament, right? And so what you can see here is you get a tear, and you even get a little bit of an avulsion of the vertebral body. So that's one type of whiplash that you can have. On the right, you can also get a whiplash injury of your dens. So if you pull forward, you can actually fracture your dens, which is C2 of the cervical column.
What is C1 again?
C1 is so you've got the atlas and the axis, right?
Okay.
So C2, that's the axis, and that's where the dens is, right?
Okay.
Yeah. So just be aware of that. You can get a fracture there. This is another one where they love questions about pathology like this because you have to understand the anatomy, but then you also have to understand it in a clinical scenario. Okay, is that our last slide over the back?
Yeah, I think so.
Okay.
But here we just have some summary tables that you can find in Gilroy. Just something good to look over before going to lab or going into a test, because it just summarizes everything in a nice table. So we have it for all of the muscles of the back.
Mm-hmm. And these are definitely, we're not going to waste your time and explain all these to you because you can read them on your own, but they're worth knowing. If you understand the actions, the innervation, and the blood supply, then you'll be able to guess on a test pretty much any insertion point of most muscles. So that's kind of where I would spend my time if I were you. Okay, so that was your first lab. All right, so group A, that's the back. Group B, you'll review that, and now you're going to go into the upper limb, which is kind of the scapula and the rotator cuff. So this PowerPoint and this presentation, it's not about everything, but we're going to focus on what's really important. So that's your deltoid. You probably already know that just from going to the gym, but it's the main adductor of the body, or of your shoulder. So it's innervated by the axillary nerve, and there's the posterior circumflex humeral artery and deltoid branch of the thoracoacromial artery that give it its blood supply. So levator scapulae sounds like it does elevation, right? So it's also going to raise up the scapula. So it's innervated by the dorsal scapular nerve, and its blood supply is the dorsal scapular artery. So that's a pretty nice one to remember. So the supraspinatus muscle, we're starting to get into the rotator cuff. Supraspinatus does the first 15 degrees of abduction, so lifting your arm, pulling it away from the body. So it's innervated by the suprascapular nerve and the suprascapular artery. Then you have the infraspinatus muscle. So the supraspinatus was in the suprascapular fossa, and then right below the spine of the scapula, that's the infrascapular fossa. So that's where your infraspinatus muscle comes through. It is innervated by also the suprascapular nerve, and the suprascapular artery provides its blood supply. Then there's teres minor, which is innervated by the axillary nerve, and its blood supply is the circumflex scapular artery. And then there's the teres major muscle, which is below minor. So it's based on size is what their naming convention is. And that's innervated by the lower subscapular nerve, and the blood supplies the circumflex scapular artery. Okay, so we've covered almost all the muscles that are involved in the rotator cuff. Joe, do you want to tell them what the rotator cuff is?
Sits. That's the best way I can remember
yes,
it.
Sits. So what is
SITS? Supraspinatus, infraspinatus.
Teres minor and subscap.
That's right.
Yep.
That's a good acronym for you to remember on your tests because it'll be useful.
Definitely. You're going to get a lot of questions about the rotator cuff. So the main thing to remember is that the rotator cuff is really where all of these muscles insert, and they hold your humerus into the glenoid fossa and the glenoid cavity. So it's what's keeping your arm or your shoulder from popping out of place. That's the main role of these muscles. And then they move it, but that's their main role. So if anybody asks you, what's the main role of the rotator cuff, it's keeping your head of humerus in place. So we've seen supraspinatus, infraspinatus, and teres minor. The last part of the rotator cuff is subscap or subscapularis, right? So I want to explain the view we're looking at real quick. So on this side, you've got a posterior view. So here you can see supraspinatus, infraspinatus, teres minor down here. Subscap is on the anterior view. So what's missing here is the chest. You're missing kind of pec major, pec minor, which you'll get into in later dissections. and you're looking at the anterior portion of your scapula. So that's where subscap starts, and then it comes over and it attaches here on the humerus. Now, the reason I'm spending a lot of time to explain this is because this can be a confusing way to look at the scapula when you haven't done the other parts of anatomy yet. And you can tell based on where the muscles connect what their actions are. So subscap connects on the medial side of the humerus, so it's going to do adduction and medial rotation of the humerus. So subscap is also innervated by, what is it, the subscapular nerve?
I think so.
All that out. Okay, so it's the subscapular nerve, two branches of it, the upper and the lower part innervate, and then the subscapular artery. So those are the 4 muscles that make up the rotator cuff.
So sits, remember sits.
Sits is very important. Live by sits.
Just another view. It's going through the other rotator cuff muscles just one more time. And so here's just kind of a summary of rotator cuff injuries, did we get into them super early in anatomy, or do we focus more on that later?
It's going to be, whether you learn it now or you learn it at the end of your module, it's going to be mentioned in this module, for sure.
So I feel like this is kind of a good point to mention, is that the supraspinatus tendon is the most commonly injured in any kind of rotator cuff injury. So I feel like if you get a question and you absolutely don't know it, just guess that one.
And if I might add, a baseball pitcher is where you're most likely to see the infraspinatus get injured.
Yep.
Yeah.
That's Anki right there for you. So just like Joe was saying, if you have a picture, so this is a great picture down here. This is actually, what page was this in first aid?
I'm not sure.
If you go to the musculoskeletal section of first aid, this is a great picture. So you can see subscap, supraspinatus, and infraspinatus, as well as teres minor and where they connect. You can tell what movements they do based on where they connect. Okay, so if you have somebody come in, and like Joe, if you have somebody come in and their supraspinatus is impinged, what aren't they going to be able to do?
They're not going to be able to abduct their arm from 0 to 15 degrees, basically.
Exactly.
If they do it, it's going to be very painful, and they'll have limited motion in doing so.
Mm-hmm. So like a great vignette for what you're going to see is like an older man or an older woman comes in and they can't brush their hair anymore, or they can't reach up to get the bowl that they need to, eat cereal in the morning. It'll be something like that written in the question. So if you have trouble abducting your arm from 0 to 15, it's probably supraspinatus. That's really common.
15 to 90 degrees is the deltoid.
Yep, 15 to 90 degrees deltoid.
And then 90 to 100 degrees is the trapezius. Mm-hmm. And then the serratus anterior is above 100 degrees.
Yeah. So there's a good table in first aid that's on the same page as this that has all of those degrees of abduction listed, so that way you can remember that easily.
So now we're going to talk about shoulder dislocations. Anna, do you want to talk about this one?
Yeah, so I think the main takeaway point with shoulder dislocations is that anterior ones are more common, because if you think about it, your scapula is in the back, so it's kind of preventing your shoulder from going too far backwards. So anterior ones are going to be more common, but I mean, as you can see, posterior ones can occur too.
Mm-hmm. So I don't know if you guys remember this, but kind of if you have a posterior dislocation of your humerus, it's going to be way worse, right? Like it's going to be a really traumatic accident. It's going to be like a terrible car accident
or something crazy.
Yeah. Whereas like if a kid is falling out of a tree and grabs onto a branch, they'll probably have an anterior dislocation of their shoulder.
It's easier to rip it out forward rather than
and the presentation that differentiates the two is internal or lateral rotation. So I think with the posterior, correct me if I'm wrong, posterior dislocation, the arm's internally rotated. And the anterior, it's going to be externally rotated.
And again, just some summary tables of all of the muscles in the shoulder region and the rotator cuff. So you guys can just look over these before your test or before going into anatomy.
And the arm will be abducted on both of those.
Okay, so we wanted to make this video really short, really high yield. I think we touched on a lot of the stuff that you'll hear about that they could trick you on. This slide is about useful resources that helped us. Part of the reason we made this PowerPoint is because we wanted something easy to digest, but you cannot rely on us. We're just first-year medical students, and we just went through it.
Technically
So,
second
oh yeah, rising second year. So we asked everybody. We said, what did you use to get through this? And this is a slide that we feel like sums up a lot of stuff that's helpful in anatomy. I've actually got the king of Anki with me to my left right here, Joe. So Joe, do you want to tell them about Dope Anatomy and Anki flashcards?
Yeah. So if you just go on Reddit and search Dope Anatomy deck or Zenki, you will find a page kind of with a bunch of decks you can download, and you'll need to download the Anki application in order to use the decks. But I would highly recommend it because they're pre-made decks and they've got content information for step 1 that is going to be high yield. So the more you flip through these cards, the more you'll be prepared for your boards in 2 years. So those are definitely highly recommended.
So what is
resources.
Anki? Because I didn't know what Anki was when I first started.
Yeah,
So
me
you
neither.
might have. So what is it?
Anki is basically just an algorithm of
A flashcard
flashcards.
app.
So you'll get a card and you'll see it one day, and if you get the card right, you'll see it again in a number of days, and if you get the card right again in those number of days, you'll get the card again in like 10 days. So it'll just keep distancing out the card. If you get it wrong, you'll just see it the
More
next day
frequently, yeah.
more frequently. So it's basically just an algorithm just showing you more cards.
It's just a good way to review and cement the information that you're learning in class and through your readings, because then you're just repeating it and repeating it and repeating it, and that helps you remember.
Yeah.
It's so much easier using Anki. I've done it both ways now. I didn't get on the Anki ship till second block,
Yeah, me neither.
and I went through Dope Anatomy, and it makes your life so much easier. So definitely do that, and you can find any of us when you come in this semester and ask us for help, and we'll be more than happy to set you up.
Find Joe.
Yes, find Joe.
Don't find me.
Okay, we've also got Netter's presentation. That's where we got a lot of our images from, so that's really great. We've got it on a Google Drive, so we can definitely share that with you too if you come find us. Or if you email the surgery interest group email, which is
surgeryigmusm@gmail.com.
So shoot us an email if you want help with that. The Noted Anatomist is actually a guy on YouTube. I don't remember what. He might be like University of Indiana or somewhere, but he's got great videos, great sound effects, much more fun to watch than reading Gilroy. So Ackland, I've already mentioned that once, but if you go to the Skeleton Library, which is our Mercer Medical School library, there's a link to that, and you have a subscription. There are great videos, and there's practice questions on those videos where they use real cadaver images. I cannot stress that enough. That is maybe the best resource other than Dope Anatomy on the list that I used.
Yeah, I used UMich Anatomy a lot. So if you just Google UMich Anatomy and follow the links to the first year foundations link, they'll have practice questions. They have PowerPoint presentations with pictures and especially cadaver images. So that really helped me because on tests they're gonna show you cadaver images and not like cartoon images that you see in textbooks. So it's nice to be able to just get more familiar looking at cadaver images, or if you just want to prepare before you go into anatomy lab, that way you know kind of what you're going to be looking at.
Yep. And then there's also Radiopedia. So that's just a great website. That's where we got our x-ray images from. So that's a great website to go to because you'll also, other than cadaver pics, you'll get a lot of pictures of x-rays and
x-rays,
MRIs.
MRIs.
So it's good to familiarize yourself with that now. And then as always, there's the Surgery Interest Group Facebook page where maybe you have something specific that you'd like help with or a question, or maybe you just want to tell us how great this video was and how it helped you make 100 on your test. Maybe not. But definitely go there. That's going to be a resource for you, and hopefully this is the first of many helpful presentations we can do. So thank you very much for listening.